Welcome back to Chapter 17. This is lecture number 7. Be sure that you're clocked into Virtual Time Clock to get credit for this lecture. All right, so here we go. Chapter 17, we're beginning with the epidemiology of cardiovascular disease and also some very significant changes in the vascular system and what affects as far as the when we're treating patients and examining patients out in the field for cardiovascular emergencies. All right, so epidemiology of cardiovascular disease, according to AHA, cardiovascular disease is the leading global cause of death. It's estimated that 1 in 3 Americans has one or more types of cardiovascular disease. Coronary heart disease, or CHD, is a disease of the coronary arteries and associated with the signs and symptoms and complications such as angina pectoris and also acute myocardial infarction. Patients with coronary heart disease have 5 to 7 times the risk of having a heart attack or from dying, period. Characterized by arteriosclerotic narrowing of the eventual blockage of the arteries that supply the heart muscles with blood. That's where you end up with coronary heart disease. It's where the plaque sticks to the inside of the coronary arteries, and then eventually that plaque will plug up because of the fact that the red blood cells are sticking together because they're moving too slow through the narrowed passageway. So acute coronary syndromes, or ACS, it's characterized by diminished flow through the coronary arteries, coronary artery occlusion by blood clot, or what we call thrombus, coronary artery spasm, reduction of overall blood flow from any cause, and if a blood vessel becomes blocked, tissues that are deprived of oxygen and nutrients turn into what we call ischemic tissue. Otherwise, there is ischemia in that area. When this ischemic process is not interrupted, otherwise we don't get that blockage out of there, tissue dies, which therefore we call that infarction. Etiology. The usual cause of ACS is the rupture of arteriosclerotic plaque. Otherwise, the plaque breaks loose, it goes somewhere, and it blocks the artery completely. Arterial sclerosis or atherosclerosis affecting the inner lining of the blood vessels. It leads to that narrowing of the blood flow reduction through those vessels. The atherosclerotic process is as follows. Small amounts of fatty material is deposited along the artery's inner wall. Fat gradually enlarges and becomes mass of fatty tissue, which we call atheroma. The atheroma eventually calcifies and hardens into a lesion. The lesion infiltrates the arterial wall and diminishes its elasticity while decreasing the amount of blood flow through the lumen of that vessel. This area is the ideal site for any formation of a thrombus, which can obstruct the artery altogether. Calcium may also precipitate into the arterial walls, causing arterial sclerosis, reducing arterial elasticity. Types of risk factors, these are several risk factors that do exist. More than 90% of coronary heart disease events occur with people who have at least one of these. Some are non-modifiable risk factors, others are definitely modifiable. Risk factors for CHD include hypertension, cigarette smoking, diabetes, high serum cholesterol levels, lack of exercise, obesity, family history, and male gender. People can address their following factors, making them modifiable risk factors, such as diabetes. Patients can lower their risk of coronary heart disease, cerebral vascular disease, peripheral vascular disease, and heart disease by improving their overall health. Excessive alcohol consumption. People can lower blood pressure and triglyceride levels, which can be raised by excessive alcohol. High blood pressure. This is a risk factor for heart disease, stroke, and end-stage renal disease. Although hypertension cannot be prevented or cured, it can be controlled with diet and medication. A diet high in saturated fat and trans fat and cholesterol, people can lower their risk of atherosclerosis and heart disease and cholesterol by lowering that intake of the saturated fats, which could also reduce the risk of heart attack, cholesterol, and can be controlled with medication if necessary. Obesity. Patients with obesity also have an increased likelihood of other coronary heart disease risk factors, such as high blood pressure, diabetes, high cholesterol. A sensible diet with increased physical activity can lower the risk of coronary heart disease. Lack of exercise. Exercise improves overall fitness, cardiac reserve, and collateral coronary circulation. Cigarette smoking. Smokers who quit return rapidly to the same risk level as non-smokers. Stress levels. People who learn to manage their stress more effectively can lower the risk of coronary heart disease. Other contributing risk factors: education, family income, and employment. Angina pectoris. It is a principal symptom of cardiac coronary artery disease, or CAD. Pain that occurs when the oxygen demands of the myocardium is not enough to meet the demand. A switch to anaerobic metabolism leads to a buildup of carbon dioxide and lactic acid within the myocardium. During exercise or other physical stress, the patient may not have enough blood flowing to the myocardium to satisfy the increased demand for the oxygen. If angina occurs at rest, the patient has a more severe coronary artery disease. It is important to be able to distinguish the differences between stable and unstable angina. Stable angina follows a very recurrent pattern. Pain occurs after a predictable amount of exertion with a predictable location, intensity, and also duration. Patients often take some form of nitroglycerin for treatment. ST segment depression or inverted T waves show on the ECG, and ECG changes resolve when the heart's oxygen demand is met. Now, unstable angina, just on the other side of that, is more serious and indicates a higher level of coronary artery obstruction. It is usually characterized by changes in frequency, severity, and duration of pain and other symptoms. More frequent and severe attacks, which may also become on or overwhelm the patient during sleep or at rest. This is a definite warning signs of an impending MI, and if folks don't listen to that warning sign, they may end up having an MI and not surviving for that. You also have Prinzmetal angina or vasoplastic angina. This is caused by coronary artery vasospasms as a result of chest pain at rest, so it's actual spasms of the heart. Usually these things are caused by emotional stress, hyperventilation, exercise, and also cold weather. It can also occur in patients with normal coronary arteries as well as patients with CAD. ST segment elevation is very common on the ECG with these patients. Resolution and symptoms are on their own with either rest, relaxation, or even with nitroglycerin. There's definitely an increased risk of dysrhythmias, AMIs, and syncope and sudden death in these kind of patients. So acute myocardial infarction, or AMI, some pathophysiology about it. It's part of the cardiac muscles are deprived of coronary blood flow for a long enough time that the portions of the muscles begin to die. The location and the size of the infarct depend on the artery that's blocked and where it's located. Most infarcts involve the left ventricle. When the anterior, lateral, or septal wall of the left ventricles are infarcted, it usually is from an occlusion of left coronary artery or one of its branches. Right coronary artery occlusion usually causes inferior wall infarcts. Subdenocardal myocardial infarction is when the ischemic process affects the inner layer of the muscle only, and then transmural myocardial infarction is when the infarction extends through the entire wall of the ventricle. Infarcted tissue is surrounded by a ring of ischemic tissue that is relatively deprived of oxygen but is still viable. The tissue is electrically unstable and may be the source of the cardiac dysrhythmias. Patients with STEMIs have ECG evidence of ST segment elevation. NSTEMI or non-STEMI produces no sign of myocardial injury on the patient's ECG. Distinguishing patients with unstable angina from those with AMI may be impossible during that initial presentation, but signs and symptoms and ECG findings associated with the two conditions may be identical. So assessment. Bottom line, the goals is to identify whether a STEMI is present or not. Determine the time of the onset of symptoms, monitor cardiac rhythm and vital signs, and be prepared to provide cardiopulmonary circulation artificially if necessary and to include defibrillation. Administer appropriate medications and transport them to the appropriate facility. The most common, absolute most common symptom is chest discomfort. Although some patients may have a history of stable angina or acute coronary syndromes, recurrent will be initially presenting themselves with coronary artery disease type of symptoms. Pain is felt just beneath the sternum and may be described as heavy, squeezing, crushing, or tight. The pain radiates to the arms and to the fingers and may radiate to the neck, jaw, and upper back or epigastrum. The pain is dull and unaffected by deep inspiration, movement, or position, may or may not be relieved by nitrates or rest. The pain often unconsciously clenches a fist when describing, or the patient often unconsciously clenches a fist when describing the pain. This is called Levine's sign. The pain is sometimes mistaken for indigestion. Too many people blow that off as indigestion, especially females. And then they'll end up, females with diabetes that have had children, especially because there's a level of tolerance that they can take from the pain. And then also, if they're diabetic, they have some level of neuropathy. All right, so not every acute coronary patient has chest discomfort, just chest discomfort. These are called silent MIs. Others may present solely with dyspnea or with arm, shoulder, back, jaw, neck, epigastric, or ear discomfort. This table here is table 17-11. It's on slide 252 and it's in your book. It tells you the different characteristics of anginal equivalents. So symptoms. We talk about women. We talked about this a little bit earlier. Their atypical or unusual symptoms are more common in women, older adults, and patients with diabetes. Chest discomfort that presents more of an aching kind of tightness or pressure, burning sensation, or discomfort that may come and go, shortness of breath, weakness, nausea, and vomiting. Other symptoms, older adults, they usually have compromised mental status, so they may have a difficult time in being able to describe to you the type of pain it is. They also have generalized weaknesses, and they may also have syncope and shortness of breath. Patients with diabetes, generalized weaknesses, syncope, lightheadedness, and diminished mental status, and not as much pain as most other patients. So there's lots of things to take note of when we're doing our assessment. So we're going to ask the usual sample and OPQRST questions, but also determine if the patient has taken any pain medication and if it helped, or if they take any anti-clotting medications on a daily basis, such as aspirin. If the patient took nitroglycerin and got no relief, establish why the pain was unrelieved. The patient may be having acute coronary syndrome because if it's not relieved at rest, it's not relieved with nitroglycerin, it's probably an MI. The nitroglycerin may have gone stale though, so you need to make sure to check the expiration date and check how it's stored. Ask the patient whether the last few doses of nitroglycerin have had any usual effects such as the burning of the tongue or feeling flushed. If it has not, then it may be an ineffective medication. ACS patients with STEMI and management of these folks start the treatment at once on the arrival of the scene for a patient with chest discomfort because it benefits the patient, and time is very sensitive to this. Time is muscle. The more that we can start to relieve the stresses on the heart, the better off the patient was going to be. Refer to the ACS algorithm in figure 17-103 as far as doing that secondary assessment and continuing your assessment. Place a patient at a physical and emotional rest. You want to loosen all the clothing up, make them comfortable, and begin to talk with them and give them some information that you're there to help them, and you're going to look at identifying whether they're having a heart attack or not. The more anxious they get, the more oxygen that their heart starts to use, and more it's going to demand. So therefore, the less is going to get to it as it begins to increase in rate and contractility. So it's going to hurt even worse. So you need to work with them, try to calm them down as best you can. To begin your treatment, place them in a semi-Fowler's position. Don't allow the patient to walk to the stretcher. These are not good things. From the first point of the paramedic's arrival, the patient must not do anything. Don't do anything to aggravate this. Obtain vital signs and perform cardiac monitoring. Measure blood pressure at least every 5 minutes and measure their pulse rate. Perform cardiac monitoring. Listen for rhythm irregularities. So we're going to oscillate the heart and see if you hear anything that's weird, anything that's not supposed to be there. Keep your cardiac drugs close at hand. Treat pulses, pulseless rhythms, tachycardias, and symptomatic bradycardia in accordance with the algorithm from AHA. And of course, initiate CPR, defibrillation, and cardioversion if indicated. So, administer oxygen and aspirin. The mnemonic MONA is used to help remember treatment, although it should be given in the following order: oxygen, aspirin, nitroglycerin, and morphine. Do not get to your nitroglycerin and your morphine until after your 12 lead. We must identify with these patients if they're having a right-sided MI. If we do a standard left-sided EKG and we find that they're having an MI on the left side, then it's okay to proceed with nitroglycerin and morphine because we know it's not in the right side. The right side is preload dependent. If you give patients nitroglycerin or morphine, both of those are vasodilators, you run the risk of removing their cardiac preload and causing cardiac arrest. So get your 12 lead first. If it's in the left side, fine. If you don't see anything on the left and you move your leads to get V4R, R7, 8, or 9, okay, then you need to start thinking, do I have one on the right side? So when you move those leads over and you do your 12 lead on the right side and you see your MI, don't give your nitroglycerin or morphine unless you're absolutely sure that the patient's pressure is high enough to tolerate it. You might want to choose some other pain relief, like fentanyl. If a patient is dyspneic, hypoxemic, or obvious signs of heart failure, administer oxygen and titrate the therapy to maintain SaO2 somewhere around 94% or higher. In most EMS systems, dispatchers may also advise patients to choose baby aspirin. That dosage is between 160 and 325 milligrams, unless there's an allergy. Obviously, if the patient has allergies to aspirin, they're not going to do that. Get your 12 lead, perform before administering any medication. I can't say that enough. Before administering any medication, because it's going to guide your treatment therapy. Repeat the 12 lead ECG each time a set of vital signs or when symptoms change or as often as necessary. In patients whose symptoms suggest ischemia or infarction, the 12 lead allows for rapid stratification in one of three categories: STEMI, non-STEMI, or normal. This figure shows ST segment elevations in 2, 3, and AVF with ST segment depression and T-wave inversion in reciprocal leads 1 and AVL. So if you look at this, you see 2, this is 2 at the bottom, 3, and AVF, okay? And your reciprocal changes are definitely in AVL because you'll see depression, there it is, and also in lead 1. That is an inferior wall MI, okay? This is absolutely an inferior wall MI because it's in those leads contiguously, 2 through AVF. That's your inferior wall, and the reciprocal changes being AVL and lead 1. STEMI treatment requires reperfusion therapy either by percutaneous coronary intervention or PCI. You're going to hear that word a lot, PCI, percutaneous coronary intervention. That's where we take the patient into the cath lab. Or you can administer a fibrinolytic type of medication such as Retaplase, Adaplase, streptokinase, those kind of things. You should know which medical facilities in your area are equipped to do PCI. Most patients and most physicians prefer to get them on a cath table. That way we can get inside and find out very quickly which coronary artery is blocked and get it unblocked. AHA recommends pre-hospital notification of the receiving facility. If fibrinolysis is likely the reperfusion strategy and or pre-hospital activation of the cath lab. So, one or the other. Need to let them know that you're coming in with a STEMI. That's why we call STEMI alerts, is so that the hospital can prepare, so they can be ready for us. Most treatment regimens for fibrinolysis include one of the three agents: Adaplase, which is Activase, streptokinase, which is Streptase, and then Retaplase, which is also called Retavase. It converts the body's clot-dissolving enzymes from plasmagen into plasmin, allowing for the clots to unblock and slip back through into the patient's body where they need to be reconditioned back into red blood cells. For patients with STEMI, it is critical to minimize the following. A, EMS to balloon time. It starts at the first moment the patient is contacted by the EMS provider and ends when definitive therapy occurs, otherwise when they're on the cath table. Next is door to balloon time. This is the interval between the patient presentation to the medical facility and into the PCI or definitive therapy in the cath lab. Then finally, if the patient decides to do fimbroliasis instead, door to needle time, which begins when the patient arrives at the emergency department and ends when a fibrinolytic medication is administered. The ideal STEMI system should have the following: well-established protocols, comprehensive training, a fibrinolytic checklist, 12-lead ECG acquisition and interpretation capability, staff experiences or experience in ACLS, ability to communicate with the receiving institution, and also medical direction with training and experiencing and managing the STEMI, and then finally quality assurance. Not all EMS systems are able to support the STEMI system. You got to remember, guys, is that out there's many different designs of systems, especially in the rural setting. It is a lot different in North Dakota and South Dakota than what you imagine here. There is very few far in between PCI centers. So most of their EMS is done by air. And you're lucky if you get to a hospital before your heart is so infarcted. So they may have some options in the field. They may have more advanced options, such as TPA, or doing some streptokinase in the field, a fibrinolytic in the field once it's been diagnosed. So anyhow, it all depends on where you're at. Transport patients with STEMI to a facility capable of performing PCI is number one. Do not administer fibrinolysis to patients with unstable angina or in STEMI. Patients with unstable angina or in STEMI who are clinically unstable or who have positive cardiac biomarkers may undergo PCI. So providing pain relief, that's a big number one. Administer nitroglycerin if there's no contraindications. Ensure the patient does not have an initial systolic blood pressure of less than 90. Avoid administering nitroglycerin if there is a right ventricular infarction. Okay, because hypertension can result when preload is reduced. Just like we mentioned earlier, apply a right-sided chest leads to assess for right ventricular involvement. Do not administer nitrates either if the patient also has photoinsterase inhibitors such as sildenafil, which is Viagra, or tadalafil, which is Cialis. History and secondary assessment. Make sure that we're doing a good history on these folks, because there may be some other underlying things that we need to know. There could be diabetes that's involved with these patients. There could be COPD that's involved, or congestive heart failure. Make sure that we've taken all the necessary steps to find all the information about the patient that we can. Transporting, once the patient is stable, transport in a semi-Fowler's position. Ensure the patient is as relaxed and comfortable as possible. Additional treatment may be advisable, especially for long transports. And we talk about stable. You cannot completely stabilize a patient in the field. We don't have the equipment that the hospital does, but we can make them as comfortable and as stable as we can get them in the ambulance, and take them up to that point, get them in the ambulance, and then get them to a PCI center. Some patients refuse care despite having the signs and symptoms that are very consistent with acute coronary syndrome. You need to talk to these people. You need to tell them what those risk factors are, and that if you go away and leave them there, that they very well may die. Calmly try to persuade these people into going to the hospital. If you suspect an MI, tell the patient, use non-medical language such as heart attack instead of MI. Explain the risk, including death, and the benefits of accepting care. And then contact medical direction if necessary. If you're unable to absolutely convince the patient, make sure you document real well on a refusal, because this person very well might be dead in the next several hours, if not minutes. So patient and family education is really good. So, that's why we've really gotten into involvement with public education with the American Heart Association, and a lot of pamphlets and information to schools, to workplace, because workplace MIs happen a lot. That's why we're doing a lot of training of first aid, CPR, making sure AEDs are there, those kind of things in the workplace. All right, heart failure. Heart failure is another epidemiology. This occurs when the heart, just bottom line, can't pump fast enough to keep up with the demand. Plain and simply. It cannot get enough pump going on to empty all its chambers effectively. So what happens is that blood backs up into the systemic system, in the pulmonary circuit, or even both. Heart failure is a syndrome, not a disease, and it's caused by any of the several disorders that impair the ability of the ventricles to fill or eject blood. Identification is based on symptom of onset. The ventricle is initially involved, although failure of either ventricle can occur by itself. They can also occur together as well. Causes, primarily disorders of the pericardium, myocardium, and endocardium, or the great vessels, such as in coronary artery disease. So, let's talk about physiology of heart failure. How does this work? Well, cardiac output is equal stroke volume times the heart rate. So, when we have things that affect that, anything that affects the preload, the afterload, or the cardiac contractility can put you into heart failure. Any condition, such as anything that affects it, can cause your heart failure. According to Starling's law of the heart, increased venous return augments preload. I want you guys to highlight this in your book, gals, guys, wherever you're at, need to highlight in your book about Starling's law, because you will see that information in the future. As the heart muscles, fibers are stretched in response to the expanded volume of preload before contracting. The stretching allows for the heart to eject more forcefully the additional volume, therefore boosting the stroke volume. In a normal heart, the greater the preload, the greater force of ventricular contraction, and the greater stroke volume, resulting in increased cardiac output. So, left ventricular failure, two types, systolic failure and diastolic failure. Systolic failure is left ventricle does not contract normally and has trouble pumping out all the blood to the body. So this is to the body. Diastolic failure is a little bit different. So left ventricle contracts normally but has become stiff. It impedes the ability to be able to relax and fill with blood between each contraction of the heart. Common causes of this is faulty heart valves, acute myocardial infarction, cardiac myopathy, and then excessive volume or pressure. Left ventricular heart failure, the blood backs up behind it, causing a chain reaction. The right side continues to pump normally. The left side cannot keep up, and the pressure increases. Pressure within the pulmonary system itself, the vessels themselves increases, and then fluid is forced out of the pulmonary capillaries into the alveoli, causing pulmonary edema. So remember, with left ventricular failure, your blood's going to back up into the lungs. The buildup of fluid widens the gap between the alveoli and the capillary membrane, impairing the diffusion of oxygen and carbon dioxide. Right ventricular failure is a little bit opposite to that. It's when the injection of the blood within its walls, the right ventricle must overcome high pressure and congestion within the pulmonary vessels. When it cannot keep up with the increased workload, the right ventricle fails. Blood then backs up into the venous system. It backs up behind the right ventricle, raising the pressure in the right atrium. So, blood backs up into the superior and inferior vena cava. The veins become congested with blood. Organs become congested with blood. Rising pressure within the veins forces serious fluid through the capillary walls and into the body's tissue, producing edema. So peripheral edema is most apparent in the feet and the ankles. Serious fluid may also build up in the abdomen, the pleural cavity, and the pericardial cavity. If right ventricular failure progresses, generalized edema of the entire body may occur, and this is called anasarca. Make sure you highlight that in your book, anasarca. Cor pulmonale, right ventricular function or right ventricular failure may occur by itself without left ventricular failure. In this condition, it's called, it's RVI, pulmonary embolism or pulmonary hypertension. Pulmonary hypertension is a disorder in which the pressure of the pulmonary arteries is higher than normal. The right ventricle must work hard to overcome the increased resistance to the ejection of blood. The right ventricle then enlarges and eventually fails. Right ventricular failure is caused primarily by pulmonary disease, and we call that cor pulmonale. So, if a patient has COPD and they're in right failure, we call this cor pulmonale. Don't forget that. That's a great test question for you to see. So it takes a combination of heart failure, ventricular right heart failure, with COPD. We call that cor pulmonale. Some of the compensatory mechanisms, these are mechanisms that attempt to improve cardiac output by manipulating preload, afterload, cardiac contractility, and the heart rate. Ultimately, these compensatory mechanisms may worsen with heart failure. The sympathetic nervous system boosts the heart rate, increases the force of contraction, and it also constricts the vessels themselves. So the accelerated heart rate and the stronger force of contraction increases the heart's demand for oxygen. It also reduces the amount of time that the ventricles will have to fill, and then decreases the time for coronary artery perfusion. All right, so other compensatory mechanisms, you get stimulation of the renin-angiotensin and aldosterone system by decreasing blood flow to the kidneys. And subsequently what happens is the heart rate has to work even harder to pump against all that high pressure. So aldosterone, encourages sodium and water retention and increases blood volume, which increases ultimately preload. So it's going to exacerbate the problem. It's trying to compensate, but in effect it's going to make it worse. Compensatory mechanisms also increase cardiac output for a time, but eventually heart failure advances. Sodium and water retention enlarges the heart chambers. Ventricle walls thicken, weaken the force of the contraction, and the force of the contraction actually decreases. The heart is unable to handle the increase of volume, and cardiac output decreases. So how do we assess these patients? Well, pretty much so. Shortness of breath is going to be one of those things that we're going to see with the patient in heart failure. There's a likelihood it's cardiac of origin. It might be a heart attack, or it could be high blood pressure related, some kind of valvular disease or cardiovascular condition. These patients are going to be classic cardiovascular patients. They're going to have a cardiologist, they're going to have diuretics, they're going to have different types of medications that modify their blood pressures. These are going to be very obvious types of patients. This particular slide is 286. It is signs and symptoms present with heart failure that may be present with other conditions. Management, the goals is decrease their work of breathing. Okay, decrease the work of respiratory distress and the work of breathing. Maintaining adequate oxygenation and perfusion for these patients. Providing direct supportive efforts towards decreasing the workload of the heart. Often, even with just patient reassurance, it will help alone just because it helps to calm them down a bit. Get him or her into a position of comfort. They're not going to want to lay down. That's going to be the worst thing that you try to do. So keep them up. Keep him or her in a sitting position with the feet dangling. That way you've got a lot of encouragement of venous pooling down into the feet and down into the legs, therefore reducing cardiac preload. It also will decrease the work of breathing. Apply a pulse oximeter, provide supplemental oxygen to maintain their O2 saturation 94% or greater. Use non-invasive positive pressure ventilation to manage any pulmonary edema associated with it, any of the left heart failure especially. It improves oxygenation and perfusion by reducing the workload of breathing. So CPAP, CPAP is good stuff. Maintains alveolar inflation, improves pulmonary compliance, and also slows respiratory rate, therefore decreasing the work of breathing and heart rate and systolic blood pressure. It facilitates also the delivery of bronchodilators if you can go ahead and either bag them in or put them in junction with the CPAP. It reduces preload, afterload, improving cardiac output. It also decreases that work of breathing. Do not use non-invasive positive pressure ventilation if the patient has a compromised airway, if they have altered mental status or risk of aspiration or pneumothorax. Either one of those, you want to think about something different. Other stuff we can do, place them on a cardiac monitor, get your 12 lead, make sure you're not dealing with an MI, establish IV access. Pharmacological therapy for heart failure may be slightly different from one place to another. Sublingual nitroglycerin may be given to reduce both preload and afterload, and also including the use of morphine. Lasix, or furosemide, is really not currently recommended for treatment of heart failure and acute pulmonary edema. It takes such a long time to get that stuff on board and for long-term effects that only it's patients that are concurrently on that. Is there any kind of recommendations for that? Surgically implanted ventricular assist devices, or VADs, VADSs, may also be used in patients in heart failure. These are externally mounted on the outside and acts as an artificial ventricle. Left ventricular failure is much more common than right ventricular failure because it's the workhorse of the heart. It is the high pressure side. So the LVAD is the most common type of ventricular assist device. It's usually when you see a VAD device, it is for the left ventricle because it's failing and they're waiting on a heart transplant is what they're ultimately waiting for. So AVAD may be used for the following situations: to allow the heart to rest until the patient's heart can resume pumping function, as a bridge to heart transplantation, or as a lifetime therapy. There are several types of ventricular assist devices, and they typically consist of a blood pump, tubing, external power source that connects to some kind of controller, and also alarms. Cardiac tamponade. This occurs when the buildup of pericardial fluid compresses the heart, impairing contractions and also restricting ventricular filling. It may develop gradually by an infection or a tumor, or rapidly when caused by heart surgery, pacemaker or central venous catheter insertion, or cardiac trauma such as a stab wound or gunshot wound to the chest, and also from blunt trauma as well. Assessment of these patients, your patient's going to show symptoms of really anxiety, restlessness, shortness of breath, chest tightness, and dizziness. Suspect cardiac tamponade in any patient with any penetrating trauma of the chest or upper abdomen. If it's not from trauma, the patient may have a history of some kind of medical illness such as pericarditis or end-stage renal disease. So you need to differentiate between the cardiac tamponade and a tension pneumothorax. In cardiac tamponade, the lungs are not affected, so breath sounds will be equal, and the trachea will be midline. Cardiac tamponade does produce a classic trio of signs known as Beck's triad. Make a note of Beck's triad. That is a huge piece of your differential diagnosis with patients with cardiac tamponade in your trauma section. So with Beck's triad, you have jugular vein distension, hypotension, and muffled heart sounds. Sounds are present in fewer than half of the patients, so your primary diagnosis is going to be developed from your mechanism of injury, your JVD presence, and also hypotension. Other signs of cardiac tamponade: cold, pale, mottled, or cyanotic skin, tachycardia, weak or absent peripheral pulses, narrowing pulse pressures, pulsus paradoxus, which is a very late sign. It may be absent if the patient has severe hypotension, and signs and symptoms mimicking a heart failure. Management, address life-threatening hemorrhages and get them to a hospital right away. Put them on a pulse oximeter, treat them with oxygen greater than 94%, establish an IV en route, and get them to the hospital as quickly as possible. The only other thing that we can do for patients with cardiac tamponade, I've only done this once, and it's because the patient was going to die if we didn't do something, is pericardiocentesis. It's where we're drawing the fluid off of the heart. I did this once back in the 80s for a patient that had severe chest trauma, and he was going to die, plain and simple. So a needle is inserted into the pericardial sac to aspirate the excess fluid. Withdrawal of as little as 50 cc's may give some significant relief. And trust me, my patient was very thankful doing that, because he became from a position of non-responsive, very much so, to the state where he was going to go unconscious and go into cardiac arrest, to awake and alert. So it worked. It absolutely worked. Cardiogenic shock, pathophysiology. It may occur as a complication of shock from any cause. It may also occur if myocardial contractility is diminished because of prolonged cardiac surgeries, ventricular aneurysms, or cardiac arrest. Transient cardiac shock can also recur after resuscitation of these patients. Assessment: if family members are present, ask them about history of heart disease. The history with these kind of patients often involves cardiomegaly or some cardiomyopathy kind of problem, congenital heart disease, or recent MI. When they're compensating, they usually have a little restlessness, some agitation, some discomfort, that kind of stuff. When they're decompensated, they have decreased mental status, they're showing signs of hypoxia, that kind of thing. Management, it focuses on strengthening the contractility of the heart, because remember, that's one of those things. If we can affect afterload, preload, excitability, and contractility of the heart, this is what we're going to manage as far as being able to give some effective treatments to our patients. So if we can strengthen the contractility without increasing heart rate or altering preload and afterload and controlling the dysrhythmias, that's what's going to be best for this patient. Make sure that we're applying a pulse oximeter, sitting position, feet dangling. Get your 12 lead done. Make sure you have an IV en route, that kind of thing. Administer some trial fluid volumes to see if it helps. Give them a bolus. See if it increases their blood pressure. See if it, changes their mental status, that kind of thing. Withhold any further fluid administration if the patient deteriorates, or if you start hearing some crackles in the lungs, or if you start getting some hepatomegaly, the liver starts to swell and you get a positive jugular response. You can also use vasoactive medications to treat cardiogenic shock, those drugs being dopamine, norepinephrine, and epinephrine. All right, with that, this is the last slide to control this up. If you're instructed to give vasoactive medication, make sure you have a good IV site. Make sure that you're documenting the patient's responses. Make sure that you're very clear on what you're going to give to the patient, whether it's based on protocol or whether it's based on, direct communication with your medical direction kind of thing. Provide emotional support, except for correcting life-threatening dysrhythmias. There's no other measures that you can do for patients with cardiogenic shock. I'll say with that, we're going to go ahead and close out Lecture 7. We'll pick back up on Lecture 8, beginning on slide 301, and that will cover hypertensive emergencies and some differential diagnosis of heart problems and also deep vein thrombosis. All right, so with that, we're going to close it out. For number 7, be sure to clock out a virtual time clock, and we'll see you next time.